Wonderful. Welcome again to October's monthly lecture. This evening we are going to be hearing from Luke Reid. So Luke is our Deputy Head of Anatomy at Brighton and Sussex Medical School and has experience in teaching gross anatomy, neuroanatomy, embryology and histology across undergraduate and postgraduate clinical and sciences programs. His research interests are centered around computational airflow analysis of the upper aerodigestive tract with a focus on laryngeal, airway and inducible-laryngeal obstruction. Fab. Luke, I hope I've got that pretty much right. I'm
Yeah,
sure you're going to tell us all
yeah.
about it. So without further ado, I'm going to hand over to Luke. If you have any questions throughout the webinar, please do feel free to use the Q&A function that hopefully you can see at the bottom of your screen, and Luke will address these most likely towards the end of the talk. But I hope you enjoy, hope you find it useful, and I'll hand over to Luke. Thanks, Luke.
Thanks, Charlotte, and you absolutely nailed the introduction, so thank you very much for that. Just to echo what Charlotte said, thank you so much for joining us this evening, morning, or afternoon, wherever you are. I'm going to talk to you in three different parts today. I'm going to talk to you a little bit about anatomy, how it was historically taught, how it has developed, and I'll allude to some of the offshoots quite early on. Then I'm going to talk to you about my favorite organ, the larynx, and we'll see how some of that plays out as well. And then I'm going to deviate into some of my research and how anatomy has helped me understand that with the impact of technology. So hopefully there's a bit of something for everyone as we go through. It goes without saying, we always need to kind of look up where we come from as anatomists. Anatomy in its essence, if we split up the word coming from the Greek, ana means up, tomia means cutting. So by definition, our role is to cut up and have a look. And this is echoed throughout history as human donors and dissections have been conducted to gain this wealth of anatomical knowledge that we have. And we have so much anatomical knowledge going over the centuries and even millennia now. There are a few key characters here. Now, this is not an exhaustive list. If you look into the history of anatomy, it is interesting and it has its dark moments. Not something I'm going to touch on, but just a few people here. So Aristotle, he was a clinician in about 384 to 322 before the Common Era. So that would be BC. And he was the first person to actually use the term anatomy. So he really did look at some dissections, tried to piece together our understanding of the human body, and that contributed to the way medicine had developed. We move on a couple of hundred years, then we get Galen. Now, Galen is one of the most appraised and expansive writers of anatomy. Galen conducted hundreds of dissections. He wrote over 100 books, papers, treatises, all on anatomy. Amazing. The downside with Galen is a lot of the stuff he wrote was actually incorrect. Galen had this habit of dissecting lower animals. So this could be pigs, it could be primates, and he then applied that to human anatomy. He was just like, oh, it's all the same. And that's not the case at all. But Galen, although he wrote so many things, there were no pictures in a lot of the things that he wrote. So it became doctrine, it was sacrosanct. Everyone believed what Galen had written in his expansive works for about 1500 years. It wasn't until it actually traveled across to the Middle East, it was kind of picked apart a little bit there, it was questioned a little bit, but it wasn't until we reach the anatomical Renaissance where we have Leonardo da Vinci, the big Da Vinci himself, as a polymath, accomplished artist, engineer, inventor, all these things, and he was also an anatomist. We class him as an anatomist. He conducted dissections on humans using his artistic skill. He was then able to convey that into a lot of works which weren't published but are now being acquired. So we got a lot of information from Da Vinci. And then we move on to Vesalius. Vesalius is the father of modern anatomy. What Vesalius did was he threw out the Galen doctrine and he tried to apply his own observations. And with that, he applied artists to that and managed to record a lot of the dissections that he did. So thanks to Vesalius, we've got a modern era of anatomy, which then after Vesalius, we started to hit some of the dark times, which is what I'm going to leave behind. But you can see how dissection gave us this foundation of knowledge. In the modern times, what do we have? So if we look at modern anatomical science, what you can see on the screen is our fantastic dissection lab at Brighton and Sussex Medical School. Each year, the medical students utilize 24 human donors that are given their consent for anatomical examination. And you can see around the room that we've got various potted specimens, which are blurred out for legal reasons. But this is the room where, as a medical student at BSMS, you'll spend the first year dissecting. You'll look at the thorax and the abdomen. And then in the second year, you'll be in here looking at expertly dissected specimens, going through the limbs, going through the head, neck, and brain, and also looking at the pelvic anatomy as well. So you'll spend, if you do end up coming to BSMS, for any prospective students watching, you'll see us for the first 2 years in here as well. If you are interested to hear a little bit more about how anatomy is taught at BSMS, there's a talk by my colleague Daniel Stone, and she's given a nice rundown of that. But this is still the traditional approach to anatomical science. How was it developed? Well, in the late 1600s, we started to look at histology. So we used light microscopy, we used lenses to look at things under the microscope and see their structure, which you aren't able to see with the naked eye. In this image, we can see a section of the gut, okay, and we can see all these different colors and features, the black spots and nuclei within cells, and that unlocked another realm of understanding of our anatomical knowledge. Modern day has started to use even more techniques. So we start to look at super resolution light microscopy. You can use genetic and also staining techniques to look at different elements. Here you can see a cell dividing with the nucleus there in blue. So fantastic, beautiful images. I invite everyone to go and have a look at them if you can. The next revelation is going to be imaging. Now, this really does take that two-cut mechanism of anatomical learning into the virtual realm. Now we don't need to physically cut with our scalpels, we can cut virtually looking at imaging. So this is an example of a CT that's cut in many different planes. And here as anatomists, as clinicians, we're able to look, analyze, and pick apart some of the human anatomy and put that to good use in terms of our knowledge. And another offshoot of anatomy is going to be embryology. We like to study the ways humans develop. We often use other animals to study the mechanisms there, but you can do some research on really early embryos, but again, that's highly regulated. So there are some major offshoots of anatomical science. What about some of the applications? We can look at imaging. Imaging here, we're looking at the hand, and the hand has been x-rayed, and you can see how the bones form at different years of age going through. Now, one, this is fascinating. Two, this is good clinically to know which bones are around, but it has other uses. So I had colleagues in a previous institution who are forensic anthropologists, and sometimes there would be an infant or an adolescent that wouldn't be able to speak English or wouldn't understand know their name, or for some reason, they could then put their hand up, x-ray their hand and age that individual and help find where they may belong. So again, it's a really useful tool. And another thing I'm going to talk about now is medical device development. Anatomical science is reaching vast across all these different subspecialties, but medical devices and helping them become more efficient and more appropriately placed is something that we do utilize donors for. So here you can see a reconstruction of the lower limb with the arterial supply. And here they're putting the lower limb in different positions to see what happens to the vessels. Why are they doing this? Because if you can understand what happens to the vessels and the stresses that are placed on them in different positions, you can design stents that fit in them with a lot more ease and have a lot more durability. So it does help medical device development as well. Okay, so I'm going to ask you to get your phones out, look at the screen, and we're going to move on to some specific anatomy. So here, I would like you to scan this code, if this works for us nicely, and I want you to try and name some of the major organs and body systems that you can think of. I'm going to give people about a minute or two to just jot as many down as you can. You can put in multiple answers if you wish. Fantastic. We've got lungs coming up. We love that. Brain, heart, endocrine. Excellent. Keep them coming, folks. If you can, think of an obscure organ that you know. Perfect. About 15 more seconds. This is really nice. Fab. Okay, right. Stop there. So We've got pancreas that's come up quite a lot, skin, heart, fantastic, lungs, and I can see the larynx in there. And that is the one that I really wanted people to say, because that's what I'm going to talk to you about now, right? But first, before we talk about the larynx, we're going to talk about the respiratory system. So breathing and the respiratory system are crucial to life. They are vital. If you cannot breathe, life does not work efficiently or be self-sustaining. So we need to use the respiratory tract and respiratory system to draw air from the atmosphere into our lungs, where it can then transfer oxygen into the blood supply, get rid of some of the unwanted carbon dioxide, and you can breathe that back out. Beautifully efficient, really, really useful. There's some bits of anatomy here which I think are worth going over. So if we look at the top of the respiratory tract, we have the nasal cavity. Then we hit an area called the pharynx. That's the throat. It's a big muscular tube at the back. Then we hit the larynx. We go a bit forwards. And the larynx, I'll explain all about that. Then we move down into the trachea. And then from the trachea, we enter the thorax. And then we spread out into the lungs. Okay. I want us to think about some other functions of the lungs and how breathing does help us to achieve some other functions. Air, bringing air in is fine. Gaseous transport and gaseous exchange is another. But what about speaking? By speaking to you now, I am utilizing my respiratory system in order to generate sounds and push air out so they can be heard. All right. I'm also able to protect my lungs. Okay. There's a very important mechanism of protection that occurs throughout the respiratory tract. And also olfaction. Olfaction, smelling. Okay, just at the top of the nasal cavity, you see this little blackened area. That is going to be where the olfactory nerve sits, and any smells or odors, they enter the nose when you breathe in through your nose, will touch those nerves, and they get transported back to the brain. So remember, there are some additional functions that are important there. Voice, speech, and protection are things that I am going to cover. I just want to get you to glance at the right-hand side. Can we see how the nasal cavity and pharynx are part of the upper respiratory tract? And then the larynx and everything on the bottom half of the screen is going to be the lower respiratory tract. I want to focus on the upper bit and a little bit of the larynx there. So what we're seeing is like a midsection of the head and a bit of the neck. And I've called this the aerodigestive tract. One, because yes, air will come in through our nose, hit the pharynx and go through the larynx, making its way to the trachea and lungs. Another route for air to come in is breathing through your mouth. Okay, if you're very tired or if you've been for a long run, sometimes you need to breathe through your mouth to make it more efficient. But also is that food can enter this pathway as well. So food will enter your mouth, your oral cavity, pass to your pharynx, and then make its way down to the esophagus. Right, and if we look at the bottom right hand of the screen, there's a small tube that's collapsed. That's the esophagus as well. Something that helps food not go into the larynx is this little cartilaginous structure. That's called the epiglottis. Okay, the epiglottis is actually flappy. It's quite elastic. So as food falls down, it covers this hole for the larynx and then just guides the food down into the esophagus as well. Now, this aerodigestive tract has a couple of functions. I say a couple, there's quite a few. If we look at it, one is patency. Patency means the respiratory functions must stay open to allow air through. If we see collapse in the respiratory tract, that's usually a bad sign, and it means it's not fit for function. When we breathe in, air is warmed, it's filtered for all particulates, okay, and it is humidified. And by that we mean if it's particularly dry air, it can dry out the insides. We don't want that. So we actually have mechanisms in place to humidify and add some moisture to the air. And importantly, it will control movement. Digestive functions, okay, we have mastication, which is chewing. We have swallowing, but in medicine we'll refer to deglutition, okay. In the mouth, that is the start of the digestive process for some foods. And because we have that saliva, that helps digestion, but it also lubricates food going down. So if anyone's tried to eat a cracker and it dries up your mouth, then try to swallow, it's a lot more difficult. Whereas if you get a lot of saliva there, swallow something, it will slide down quite nice and neatly. As I mentioned, we've got smell and we also have taste in this region. And there are some really interesting mechanisms with the anatomy regarding those special senses. And finally, as a subset of functions in this really intricate anatomy, we have protective functions. filtering the air is important. We do not want things like particulates in the lungs which shouldn't be there. Sometimes we eat things which have microbes in them. Our body can fight them off, and that couples with the immune system. And we have reflexes in place. So coughing helps protect. Regurgitation, okay, or vomiting can help protect the tract as well. So it's important to have a look. I would like us to have a look at this if our nice GIFs play. This is someone swallowing. Can you try and pick out some of the anatomy that we just mentioned and see how it plays out? What I think is really interesting here is we look at the left-hand side, can we see the tongue ripple along like a big wave? Okay, it secures the liquid and then pushes it back, and then you can notice the epiglottis down here, just there, that then folds over and allows it to go down the esophagus. Yeah, really interesting. If you type into Google swallowing MRI, you'll find these all over the place. So if you're interested and want to see how it works in action, please do go and have a look. But I'm going to talk to you about the larynx. Now, the larynx is an organ of passion of mine. I find it beautifully intricate. The anatomy for it is quite challenging, and I'm going to try and break it down for you as well. But what the larynx is, you might know it referred to as the voice box, and I'm going to tell you why the voice box is the last thing the larynx ever did for the human body and for mammals particularly as well. But what the larynx is, it's a collection of cartilages, so it's quite tough. It's not quite as tough as bone, but it's not quite as soft as muscles or tendons. Okay, it's a collection of those cartilages linked together by different fibrous tissues. And if you look on the screen, can you see all this orange and red stuff? All of that is muscle. There's several muscles involved in controlling the larynx to produce either a protective function, an airflow control function, phonation. Phonation is the production of the voice. It is the sound I'm making now. Okay, it's not speech, and I'll make a distinction there. Speech is different from voice. More to come on that later, right? But can we just all just palpate, so touch the front of your throat. You can probably find what we often refer to as the Adam's apple. In anatomy, we call this the laryngeal prominence. But if you can just put your finger on it and maybe feel around, and if you try and hum, now, give it a bit of a, you'll be able to feel the vibration of your vocal cords in there. And that is then resonating up into your upper respiratory tract, and then it's able to come out the nose and mouth as sound, okay? I'll show you how the larynx helps modify that sound as well. Something else you might want to try is the larynx will actually move as you swallow. So if you try and put your finger again on the laryngeal prominence, do it carefully because it can be quite sore, and then try and swallow for me, you'll find that actually the larynx will move up and down. So there's muscles that help drive it up and down. And moving it up and down can, one, produce different sounds, but two, it's more of a digestive function. It helps get the esophagus closer to the mouth so that food has a very short passage past that. Fantastic. The larynx for humans is really important because, one, it allows us to utilize that phonation, and we are the only animal that really communicates in such a complex way using our voice. There are complexities and nuances to other animals, but I think it's going to be interesting to look at how we develop the larynx, okay, if we go along with evolution. Now, the larynx, in its essence, is a sphincter. You saw all the muscles surrounding it, okay? It is a sphincter of muscles which, when they contract, they close the larynx shut and they stop air passing through. Now, there are some fish which have a type of larynx. If I move up here along A, this is a really nice schematic. You've got the digestive tract, which is our pharynx in this case. And then you have a little bit of a respiratory outpouching. There's going to be some muscle surrounding that. It's a really rudimentary larynx, and that's from a perch, and that's a fish. There is a fish that has lungs, okay, nicely named the lungfish. And their lung is a little bit more developed. And you can see here in black, that's muscle surrounding it. That's the laryngeal muscle. And we can see different types of lungfish. As we move to the salamander, it gets a little bit more complex. Okay? There's a bit more muscle there. This line here is simulating a cartilage. Okay, and if we look at the alligator again, there's going to be an offshoot from the digestive tract, and then some muscle and cartilage around that as well. So if we even think from fish to amphibians, where they're moving, evolutionary speaking, out of water and onto land, the larynx has already started to develop. The frog's an interesting one because if you've ever seen a frog croak, they bring out their vocal sac, which is this big bulge. Okay, so it draws air in using some muscles in the bottom of the mouth. They close the nostril and then they push and compress that vocal sac, and it pushes air into the lung. Okay, and then the lung will then push air out. And if you look, there's even a small closure of muscles surrounding that lung. Okay, and that's the larynx of our nice frog. Birds are a bit of a weird one. Okay, birds, evolutionary speaking, are derivative from reptiles. Okay, think about the dinosaur line. Birds, again, have a sphincter of a larynx, but you can imagine birds make a lot of sound, right? We've all heard bird songs. Okay, they're very vocal animals. They actually have this really floppy bit of cartilage. I say floppy, it's quite rigid, but it does flop around. Called a sphinx here. So just where my mouse is, that's where a lung would be. And there's the other side. The air is pushed out and it vibrates the sphinx, makes it wobble, and that produces sound. And then the birds then modify that sound and have their beautiful calls that they have, different songs. And it's a whole area of research just looking at and analyzing bird sounds, which is not my area of expertise, so I'm going to leave it to the experts. Finally, we get onto our mammals. We are a mammal. Okay, you can see here, we look at where the larynx sits, which is just these grey cartilages in this schematic. In this Japanese sero, which is kind of like a goat, deer type mammal, it's very horizontal, very flat. If we look at a gorilla's larynx, gorilla are kind of quasi-bipedal. They are mostly quadrupedal, but they can stand up on two legs as well. Their larynx is quite high up. Okay, can you see how the laryngeal cartilages here are very close to the jaw? Yeah, there's not really a gap there. That helps with feeding functions, but it also limits their ability to vocalize. Yeah, they don't have a lot of room to modify their air before it comes out. Whereas if we look at the adult human, the human larynx has descended quite far down into the neck, which means that larynx is going to make all that sound, push it up into the head, and then the head, mouth, nose can help modify that and create different sounds. And that's the difference between phonation and voice, which are the same thing. So creation of sound is the voice. The modification of sound forms speech. Okay, so a lot of animals have a voice, not all animals can speak. My last little point in this is infants, babies, okay, juveniles. A baby's larynx or an infant larynx is actually quite high up, much like the gorilla. It's very high up in the throat and in the neck. This helps with feeding. Okay, so feeding behaviors in babies, whether they're on a bottle or they're breastfeeding, milk can come through. It's unlikely to go into the larynx. It's actually going to move around it because that epiglottis actually blocks a lot of that milk from going into the larynx, which is a good thing, but it also limits their ability to vocalize. One, cognitively, because they're very, very young, but two, the larynx is high. Okay, I want to focus on the human larynx now. Airflow control, a major function of the human larynx. As I've just shown you, evolutionary speaking, the larynx isn't a voice box, it's a sphincter. It closes and modifies how air can move in and out of lungs for respiration. Okay. Now, the vocal cords are these structures here. Okay, these structures are fibrous structures which have a lot of muscle associated with them. There's one on each side. And if you look at this red region here, that is where the trachea is. So if you were to go into the screen, you'd be moving down into the lungs. Now, when we're resting, we're just sat here, you're listening to me, okay, at rest. The larynx is slightly open because it allows a small amount of air in and a small amount of air out. We don't need to be huffing and puffing, okay, because we just don't need that extra respiration. However, if you were to take a sprint down the street, your larynx with every in-breath would widen and every out-breath would stay wide, but it would slightly narrow. Okay, it widens up to allow a lot more air in and out because that's what's necessary to maintain the amount of energy that you can produce using your oxygen. Yeah, it's all controlled with the laryngeal musculature. So if there's a pathology with laryngeal musculature, or they're paralyzed for whatever reason on one side, it can limit that, and people when they're exercising will struggle to get breaths in. I'm going to throw another little bit of anatomy at you. The term glottis, okay? Glottis refers to the vocal cords and the surrounding apparatus around it. So you can see all these little bits of white tissue coming off the vocal cords. You can see some of the musculature. All of that unit is referred to as the glottis. All right? That I will come on and I will use that terminology a little bit more later. Now let's think about phonation, generation of voice, generation of sounds, okay? The larynx finely tunes this. Now, interestingly, to generate sound, we have to close the larynx. If you look at the far right side of the screen, here, image C, we can see that we've closed our vocal cords, which is a little bit counterintuitive. So how can air get through? What happens is your lungs will compress because your thorax is compressing. It pushes air out, and it causes those cords to vibrate, much like a guitar string. It's a perfect analogy for this. You strum a guitar string, which is what you pushing air through does, and it makes a sound. Your muscles can change the pitch of that sound. So there are some muscles there which will actually cause stretching of the vocal cords. What happens if you tighten a guitar string? The pitch goes up. It's a much higher sound. If you loosen that guitar string, the pitch goes down. So your larynx can actually modify the pitch of the sounds that it produces. And then your mouth or oral cavity can shape it into things that can be understood by other humans. All right, so phonation is a fascinating and intricate process, something that doesn't get a lot of time in medical school, but it does come up as you start to go through, say, ENT routes as well. And I've kind of mentioned this already, but it'll be nice to reiterate it. The larynx produces a buzz, okay? It's not really super loud, right? That buzz, once it's initiated, as it travels up into the pharyngeal region up in the neck, it's like a megaphone. So this funnel-like region starts to resonate that sound. The sound can be resonated in the oral cavity and in the nose as well. So it creates a much louder sound, which not all animals can do, but some animals can create a very loud sound. So just bear that in mind. And then in the oral cavity with your tongue, your lips, okay, your palate, which allows air into your nose or into your mouth, okay, that all coordinates to create different sounds for speech. So vowels and consonants of the English language are oral sounds. If you were to say ing, that's going to be more of a nasal sound as well. So it's something you can look at. I would advise you to YouTube this. There's a really beautiful YouTube video of an opera singer in an MRI scanner, and you can actually see how the tongue, the lips, the palate is moving just to allow this opera singer to generate all these different sounds as well. Okay. It's a lot of information coming at you, but I want to put that into a bit more context clinically. Okay, so we're going to look at some of the research that I've conducted. I'm going to introduce you to a clinical condition that's not very well known to the general society, but it is an interesting one, and it might resonate with some of you. There are going to be some endoscopic views of the larynx shown in this, so from real patients that we see. So the condition is exercise-induced laryngeal obstruction. My interest in the larynx, before I move on, is its control of the airway. How can it be used to maximize performance, or how can its dysfunction limit performance of, say, athletes or people that are interested in exercise? This is a condition that directly relates to this. So if we just look at the screen, can we see that in the center we have a normal looking larynx? That's like if you were looking down someone's throat. Okay, we can see this triangular area. Okay, if we were to go into the screen, we'd reach the trachea, we'd reach the lungs. Around the edge, we can see bits of the larynx, right? And I hope we can see that it's blatantly obvious if we look to the left now, that actually that airway, that triangle, is now obstructed by some of the laryngeal anatomy folding in on itself. Okay, this obstruction is happening when someone breathes in. What did I mention before? I mentioned that when people breathe in, the larynx likes to open it up, okay, to allow, especially during exercise, it allows to open up and allow a lot more air through because it's required. When someone breathes in during exercise and it becomes obstructed, it can create difficulty breathing, which is a symptom of dyspnea. It can cause tightness in the throat or chest. It can create a wheezing sound. You can panic. If anyone's breathed in, I hope this hasn't happened to anyone, but if you breathe in and you feel like you can't breathe in, it's going to cause you a bit of panic, especially if it's sudden. Okay. And that's what exercise-induced laryngeal obstruction is doing. Now, what's interesting is that this condition has only come about in the past 10, 20, maybe 30 years. And it's become more and more recognized, definitely over the past decade. And how it presents is if someone's working up to peak exercise, their difficulty breathing, if we look on the right-hand side, starts to increase as it reaches peak exercise. And then this closure occurs beyond what they can actually tolerate. They stop exercising, and then this difficulty breathing, those symptoms just dissipate really quickly in under like 5 minutes. So then they'll go to their GP being like, oh, I find it really hard to breathe when I'm exercising. By the time they get to their GP, they're back to normal, they're fine. It's got a really short window of presentation. A lot of the time, it had been confused with exercise-induced bronchoconstriction, asthma, exercise-induced asthma, but that has a different profile to it. So a lot of people have asthma, a lot of people have exercise-induced asthma. But what can occur is as someone goes towards peak exercise, they're fine, it's a little bit difficult, but then as peak exercise starts to peter off, you'll find that the symptoms worsen and they last a lot longer. Okay, that's because there's more of an internal physiological reaction going on there. So looking at the history of the patient, we can differentiate between the two. But that's not the gold standard of diagnosis. Looking here at the anatomy of EILO, I'm just going to mention a couple of things because I think we've done fantastically keeping up with me up until this point. I want to look at the top right-hand side. There's our glottis. What's the glottis? It's the apparatus of the vocal cords and how they move and come together. There's a region just above this called the supraglottis. Supra meaning above, so it's the region above the glottis, which is nicely named. And it's this region, the supraglottis, which predominantly collapses. Okay? The glottis can close as well. When you breathe in, the glottis can shut, but ultimately it's the supraglottis that does it the most commonly. You can actually also have both, which is interesting, and they're trying to figure out why that might be. But just before we move on, just look at this center image here. We can see the epiglottis, that's that flappy bit that covers the larynx. We can see some arytenoid towers, that's the bit that closes. If we look here in the bottom image, the obstructed image. Okay, and there's one final piece of anatomy which I'm going to mention to you. Everything else you would have heard of. It's called the piriform fossa. Now, this piriform fossa is like an outpouching just above the esophagus. So what's happening here is that when you eat food, your epiglottis closes, and if you follow my cursor of the mouse, food curves round the larynx and then moves down into the esophagus, which would sit just where my mouse is now. And it has to pass through the piriform fossa. It's worth noting because the piriform fossa sits outside or external to the supraglottis, and that's what's important here. Okay, so I'm going to show you a video now of someone who has EILO. This is a video that was available from a French paper. Okay. Pardon me. And we'll get this to play. Okay, I'm going to take it to about a minute. So this is the rig. So if someone is suspected with EILO, they would be sent to a clinic and they would have this rig put on them. So they have a respiratory system. I'm just going to go back so I can talk to you about it. So pausing that, they'll have a respiratory rhythm, which is recording their breaths in, their breath out. It's recording their pressure. There's a lot of respiratory data which is collected. They've got this really funky headpiece on, and that's actually an endoscope. So there's a camera that's placed through their nose to the back of their nasopharynx, okay, which is really at the back of the nasal cavity, and it looks down on top of the larynx. And you can see that view there on the screen on the left-hand side. Right, so there's a couple of things which can happen. One, we can track all their respiratory data while they're cycling and working at exercise. Two, they can have a look down the throat of the individual and they can see whether the larynx collapses once they reach that peak exercise. Doesn't look comfortable, but it is tolerable. Lots of people do it. Okay. So we'll keep going with our nice video. I'm going to turn the sound off. We're going to go to about a minute 30. I want you to look here, and we've gone over some of the anatomy. This is a breath in, breath out, breath in, breath out, breath in. Can you see on the breath, on the in breaths, that those folds are collapsing and they're obstructing the airway? This is someone that's pedaling on a bike right now. They're trying really hard. Ways to treat this would be to show them the video and use various techniques so they can see their larynx and they can try to use the musculature to control it. Or if it fails that and there's no conservative management, so non-surgical, they can go for surgery and they'll start removing parts. That has had good success. Conservative management, the jury's out a little bit. We'll press on for time. So this problem where you were getting refractory asthma, which wasn't asthma, it was EILO, created a problem. And it's really stemmed from a large group in Scandinavia that's done quite a lot of work on this in Norway and across in Copenhagen as well. So there was two European societies, the Respiratory Society and the Laryngological Society. They decided to put together a task force and they published two things. One was linking up terminology. This had been described for years, but it had been called different things. So when you were researching it, there was a problem. They unified it. Two, they looked at all the literature and tried to come up with some conclusions. Okay, and I'm going to talk to you through these, and this is really the rationale for why I'm about to do some of the research I'm showing you. So who does this affect? Okay, interestingly, it mostly affects adolescents. Okay, so teens. Mostly of that teen group, it's going to be females. And of that group of teens that have respiratory issues when they run around and exert themselves, about 5 to 7% of them had EILO. Okay, those numbers are starting to shift. More studies are coming out, but be aware and take it with a pinch of salt. But it's a good portion of the population. It's a good chunk of the individuals. It's also been documented in elite athletes, military personnel, and race forces, which I found really interesting. These groups of individuals are the ones that will exert themselves and push to physical exertion. Right? Here's an image of a horse larynx that is undergoing collapsing while they're running. The anatomy is a little bit different, I'm sure we can appreciate, but the collapse is still there, and it's still occurring in the supraglottis. So how, right? How does this occur? There's a few theories. One is that there's a reflex neural dysfunction. So there's something that's stimulating the larynx to close. Psychological, those that have panic attacks or have some sort of acute psychological distress, they can find that their larynx closes. And again, that's going to be a reflexive action. That makes sense for the glottis, which has a lot of muscle. Supraglottis doesn't have that much muscle. The final theory is mechanical insufficiency. The anatomy is unable to withstand the forces that are generated by the airflow. Okay, so we don't understand the pathophysiology. There's no coherent understanding of that. So this is where I came in. I was told this by a mentor of mine up in Scotland. He's an ENT consultant surgeon with a focus on laryngology. He showed me this problem, and I was like, leave it with me. The university gave me some money, and I decided to probe a little bit deeper. The solution I came up with was using computers and computer science. Okay. I was able to take scans of individuals. I could create a really nice airway that you can see rotating around for you now. And once we have that geometry, once I have the anatomy, I can then create a computer model which allows me to push air through that and then analyze how it behaves. There's a couple of steps. So I would take this geometry and I would chop it up into fine bits. You can see that on the far right. Okay, and in doing that, it's like looking at your phone. A high resolution phone, the pixels are much smaller. Okay, it gives me a lot more detail. If that mesh and those squares were much larger, it would become blurry. So the finer the mesh, the better the accuracy, okay, as an overall concept, right? But how do I simulate air? I'm not blowing into it. I would need it to be physical for that. Into a computer, I need to push air through and see how it behaves. I'm not trying to turn you into mathematicians, but for those of you that are mathematically inclined or have an interest in physics, there are some equations which help govern how air moves. Now, air is a fluid, so how air moves through this geometry can be approximated using these equations. Okay, the first equation on the top line literally states that mass is not removed or added to the system. Okay, the next one is just Newton's second law. So mass times acceleration is the sum of the forces acting on the air. Again, I'm not trying to scare you off. It's just another application that's coming through. What does this allow me to do? It allows me to generate simulations like this. You can see how air is moving through. The red areas are really fast moving air. The bluer areas are slower moving air or still air. Okay, and in doing so, I can then analyze how the air moves and I can look at the forces acting. Okay. The stuff on the right-hand side is just in case there is anybody here that has looked into fluid dynamics, they'll understand what that means, but I'm not going to explore it. One thing I will say though is this program at the top, OpenFine, is completely open source, as is the other software that I use to generate the geometry. So I'm a big advocate for accessible science. So if you can conduct science using free technologies, I suggest you do it. And this is an example of that. It's also very cost-free. Who doesn't like that? So I'm going to very briefly just talk you through some of the findings that we had. We started to look at EILO, okay, and I took 4 normal geometries, which you can see on the screen. These geometries are all different, so the anatomy is different in all of them. They're not copies. They're created in subgroups. So if we look at the arrows, on the bottom right, image D, that sticky out bit, that's the piriform fossa. If we look at the top image with the arrow, there's no piriform fossa there. It's obscured or it's obscured in the scan. So my hypothesis was that the piriform fossa plays some significant role in how airflow behaves, as does the flow rate. And what we're looking at here is a very pretty picture with lots of pretty colors. The hot colors, reds, oranges, yellows, that is positive pressure. That means pressure is being pushed out of the airway. The cold colors, blues, light blues, they're suction pressures. Right? The area that I'm interested in is this one. Yeah. Can we see how there's no suction there at all? Now, that was the original theory that air was being sucked down into the trachea. From the computer model, that's not the case. We can see a really hot, large force pulling here, pushing there, sorry, and a very small one pushing there. Which means overall, there's a really large force pushing into the airway on both sides. You don't really see that behavior on the left-hand side, where we see a lot of blue. We see some suction force, but we know that's not the case. So we've used computational fluid dynamics to just rechange the way we're thinking about how the airflow interacts with this anatomy. Finally, we managed to create some really nice pictures here where we can see the force acting on that. We did think that actually maybe when people reach a certain flow rate, that the force is too large and it collapses. That did seem to be the case. So if we look at the left-hand side, those 2 images, that's a really low flow rate. That's like low to moderate exercise. On the right-hand side with our big arrows, that's a high level of exercise, 3 times the amount of the left. But the forces were 10 times that we found in low exercise. So there's something going on there. Finally, this is my last slide before we wrap up. we actually decided to then rope in some patients. So I worked with a collaborator over in Copenhagen. He got a group of patients with EILO and a load of healthy people that were matched for size, sex, gender, and loads of respiratory measures. And we found that the EILO patients, our model predicted the forces demonstrating collapse. And then the control patients, our model did not demonstrate collapse. It actually shows all the arrows pointing outwards. So it's really interesting. And I'm going to leave you with that. What we've looked at is a little bit of the history of anatomy and how anatomical science is diverging away from cadaveric dissection. We've had a bit of a chat about the anatomy of the larynx, which doesn't get taught at A-level biology very much. It doesn't get taught in a great amount of detail in early medical school. It comes up later. And I just wanted to demonstrate how an understanding of medicine, anatomy, maths, computational science, you can really work together in a multidisciplinary group to really understand niches of medicine which are currently unexplained. So I'm going to leave it there and I'll pass this back to Claire.
Amazing. Thank you so much, Luke. Really appreciate it. And yeah, as you mentioned, really interesting to see how all the variety of different disciplines kind of really interlink and relate with one another. I can see
Yeah.
there are some questions in the Q&A that I think you're probably more well suited to answer if you wouldn't mind taking a look and perhaps turning your attention to those.
Yeah. Okay, so the first question was Galen the one who developed the Hippocrates ideal? So no, that was actually Hippocrates himself. It was the Hippocratic doctrine that is used in a lot of medicine to kind of set the standards of behavior and practice. Is the cadaver's room smelly? It smells like a lab. Okay. Yes, the human body can have a bit of an odor, but mostly it's more chemically than not a nice smell. So it's more of a chemical smell, more like a lab. Is that basically the Adam's apple, the larynx? Yes. Yeah. The Adam's apple is that knobbly bit on the larynx. We call it the laryngeal prominence. It's more prominent in males than females, but yes, it pokes out, and you can see that. This one's a very interesting question. Would the larynx look different on a mute human? Now, this is an interesting one. I've not really been asked this ever before in my life, but the larynx is controlled by a lot of musculature. Okay, so if you don't use a muscle, it can sometimes atrophy. Okay, so it can create some difference there. There'll also be a lack of use, but they would still be breathing. So there would be some of the cellular interactions would be mostly the same. It's a very interesting question. I might have to look that up and get back to you. If you have an email, drop me an email and I'll get you an answer. When does a baby's larynx begin to descend and come down? Yeah, I think that does actually occur within the first year of their life. Can sometimes extend a little bit longer, but yeah, within the first year to 18 months. Miriam Khan. How does it work when you lose your voice? Firing is off rapid. When you lose your voice, there's a number of different reasons for this. As someone that teaches a lot and uses my voice a lot day to day, it can often be a drying out of the throat. If your throat dries through overuse, it can cause a bit of trauma, a bit more irritation, and it can cause it to swell. And if the vocal folds have any swelling or irritation on them, it can cause them to be painful, or it can make your voice seem really hoarse, is one reason. There are some more sinister reasons why you may lose your voice. This can be some sort of paralysis on one side, it gives you a hoarse voice as well. But more often than not, it's probably just due to overuse. How does the larynx and mouth create so many sounds and voices? That is a fantastic question. And if I had 3 hours to talk to you, I would love to talk to you about it. The larynx obviously generates the sound. Okay, it generates that initial hum, that guitar string pluck. It's how you then combine your sounds in your mouth and modify those sounds that creates speech and language. So obviously different countries have different languages. They utilize these speeches in different ways. It then becomes a bit more societal where how you've been taught to attribute that sound to a meaning. And I think that gets beyond my area of expertise, shall I say. but physiologically it's voice in the larynx, mouth, nose, and throat to generate different sounds. So if a patient finds difficulty breathing during peak exercise and feels panicky, so might begin to wheeze and even cry, would that be EILO? It has potential. It could also be quite a few other things. Okay, if that's the case, I would suggest going to a GP and they can refer you to an ENT. But yeah, it could be. From the symptoms that I described to you, it could be. Yeah, this is a good question as well. Towards the end of the talk, I showed you the guy on the bike with a bit of headgear on. That's how they do to definitively diagnose it. They can do it through medical history as like a general notion and try things. But yeah, they would do that. That's called the continuous laryngoscopy during exercise test, the CLE test, and that's the gold standard for diagnostics. Interestingly, they do it on a bike. You can do it on a treadmill. They've even tried it using underwater swimmer. They had a big rig for that, but that's not a common way to test for it. We've got more time. We do. What would happen? Sorry, what would cause someone to develop this condition? Can it be genetic? And can someone have it from birth? Interestingly, my collaborator over in Copenhagen, Emil, he looked at whether there was a genetic link there, and I don't think they found one. It's a really brief paper. They kind of teased it. They didn't look. So we don't know is the question, is my official answer to that. Can someone develop this condition? Again, frustratingly, we don't know. The data's not there. We haven't looked at it. We don't even know why the condition occurs, so we don't know how it can be developed or come about. But I would love to know, and I hope to over my years. If this affects individuals who have panic disorders, can it go away once they manage the panic disorder? Now, I'm not a clinician, so I'm not going to speak too much to this, but from my understanding, panic disorders usually affect the glottis. Okay. In EILO, it's most commonly to be the supraglottis. It can, if someone has asthma, it can lead them to have a higher incidence of EILO. The data is still coming in. Interestingly, with panic disorders, the larynx, yes, they can be managed. With EILO, again, if they don't reach that peak level of activity, then they don't undergo symptoms. So think about it in the case of the infant that likes to run around but can't, it will affect their quality of life, and it can just affect what they do in the future. So that's the shame with it. Hala, I think we've kind of already answered that, Hala, with the previous question. Environmental is still out. There is some interest looking at irritants that was proposed, where they would breathe something in and that would cause a reflexive response, kind of like asthma, but again, they're looking out for it. If you lose your voice, what is actually happening? I think we've covered that one. Do you think AI will have a significant impact on future research? Yes. Yes, I do. In short, I'm not an AI researcher. I find it absolutely fascinating. I haven't dedicated enough time to reading into it. Currently in the medical school with our first years, we're discussing how AI will influence modern medicine. There are some interesting routes to go down there. Personally, looking at computer science and technology, AI is already being used in the realm of fluid dynamics to create these computational models. And it's really exciting to see where that goes. But yeah, I think it will have an absolute impact. I don't know what the impact is yet. Is the larynx affected when you get illnesses like colds and COVID? I don't know about COVID. The larynx can be affected by colds and excess mucus, and that can cause an issue. Again, with things like coughs, like chronic coughs, if you're pushing a lot of air through your larynx, you're causing a lot of trauma, or a lot of stress, which can then lead to trauma, so that can affect them. But again, I wouldn't be the right person to speak to on specifics of COVID. Is the larynx affected when it hurts to swallow? When you get a sore throat, sorry, and it hurts to swallow, what is happening in that region of the throat? Hurts to swallow in the region of the throat. Okay, so if you get a sore throat, there's loads of reasons for that. It could be inflammation in the esophagus, and then when you're swallowing, food is rubbing down on the esophagus, and that can cause a bit of pain. The nerves around that area are similar to the throat itself because it's all the neck region. So it feels quite similar in that region. That's my anatomical answer. What type of research should you do for medical personal statements? Charlotte, do you have anything to add to that one?
Yeah, I was just going to say it depends on kind of what research you're talking about. Are you thinking about scientific research? Are you thinking about research into medical schools themselves? Generally speaking, we like to see that students have kind of maybe explored an area of interest that's maybe outside of the A-level curricula. Just as a general rule of thumb, we get lots of applicants who are studying the same things. Can you tell us something that you found particularly interesting that maybe sits just outside of the curricula? In terms of other research, absolutely do your research on medical schools. Everyone teaches the medicine curriculum in slightly different ways, and actually anatomy is one of the main differences in which it's taught at medical schools. So some people have a preference for dissection, some people prefer prosection, some people prefer using um, other techniques to learn anatomy. So there's lots of research that you can do to, I guess, develop your insights into both the field of medicine more generally, but equally to inform your decision about which medical school you would like to apply for. I guess a small plug for our upcoming talk on getting into medicine. So if you are considering applying and would like some further information, check out our events page and we can tell you about all the things that you should research it when you're considering applying to medical schools more generally.
In terms of anatomy, we teach it all the ways that you mentioned. So if you're interested in it all, you know where to go.
Just a little plug there.
Yeah. Um,
Luke,
are
I
there,
think we've got, sorry, I'm just conscious of time. So I'm just wondering if we just pick out a few more questions. And there's a couple that maybe touch on slightly different areas that we've not covered. Do you mind sharing? There's a question here about your educational journey and kind of how you've got to this point. Would you mind kind of just covering that aspect?
of course, yeah, and I'll try and do an abridged version. So my undergrad was actually in sports therapy. So I was very interested in sport and biology. Medicine wasn't really a route that was available to myself. Um, and something that I even considered an option. It was only when I got to university I found it fascinating. I went and studied anatomy up at Edinburgh University, which is a really long history and a profound history of anatomy. And then from there, I went and taught abroad. I taught in the Caribbean for a while, enjoyed that. And then I came back to Scotland where I completed, or we're just about to wrap up some doctoral work and spent 8 years lecturing there. And I've recently moved down to Brighton and Sussex Medical School. And from here, I will stay for a good few years, no doubt. It's quite a broad, twisty, turny journey. The one thing I will say is I've always followed my nose. I always do things which I find interesting. I don't really believe in following a set path. If you want to do something, you can generally make it happen.
Fabulous. I think that's a wonderful place to kind of draw the lecture to a close. I'm just going to pop a couple of videos in or links to videos in the chat. You mentioned Danya's talk about learning anatomy as a medical student. So just link to a previous recording that we've had. And also, I'm not sure if it was the video that you were referring to there, Luke, but there's a someone singing in the MRI. So I've just popped that in the chat. And again, we'll include those links in the email that we'll send round. I'll also try and capture the rest of the questions that haven't been answered, and perhaps Luke, you might be able to record some of the answers to some of them more generally, and we can maybe try and include those in a follow-up as well. But thank you very much for joining and for your incredibly informed questions. A virtual round of applause to Luke. I know the attendees can't show their thanks in a way that we are used to, but I'm sure they're clapping all around the world. Um, Thank you again, everyone, for joining. And again, we will circulate the recording as and when we've captioned it. So I'd like to think it will be in the next week, but we do just need to process it our end, but we will circulate it. Um, if you are interested in joining us, we've got a few other events coming up. One about getting into medicine. Those that are applying, we're doing a preparing for medical school interview webinar. Next month's talk, hopefully, we're going to have kind of a simulated ward round where we're exploring different fictional patient cases. And again, more information will be posted on the BSMS website in due course. And again, we'll hopefully include those links when we email out post talk. Thank you very much. That's everything from us. We really appreciate your time and joining us. Hope you found it informative. And again, hopefully see you in another online talk in due course. But thank you very much. And for those that are submitting applications, good luck with your applications. All the very best. Thanks, everyone.
Thank you.